go ahead and get started. Tonight we have a special guest here to talk to us a little bit about hospice and patients that we see on hospice. We see a lot of those. There for a while we thought Hal, but sorry, Hal.
Released today.
Okay, this is Amber Mall. She's been with hospice for 5 years, been a nurse for 10 years. The name should sound familiar. This is Sergio's better half.
Is it?
Is that correct? See?
Oh, easy to be the better half.
Yeah.
So she's going to go over a slide presentation. If we have any questions, remember, please raise your hand so that I can turn the camera to get your question on the camera so that whenever we put it out, everybody can hear what your question is for her. So I'll turn it over to her.
Okay, so does anybody here have a hospice experience? Ever had a personal experience with hospice? Nobody really? So you just know a little bit of it, what you hear and see in the community? Kind of? Okay, so I'm going to talk to you guys as if you're a patient or patient family member, and I'm talking about hospice. And then as you have questions, just ask. And I'm also going to interject how it affects EMS, how it affects y'all's service. What is hospice? Hospice is a service that's provided to a patient that has a terminal diagnosis, that they are not seeking a curative treatment or there is not curative treatment available for them. Our focus on hospice is relieving symptoms of the disease and whatever other comorbidities they may have. Hospice is for somebody who has what we say months versus years left of life. Hospice care is provided in the home, nursing home, hospital setting, inpatient units, assisted livings, anywhere that the patient calls home is where hospice care can be provided. The hospice philosophy is we recognize that dying is the normal process of living. We focus on maintaining the quality of life versus the length of life. We affirm life and we don't hasten death. We won't do anything that makes it come quicker, but we're not going to postpone it either. We're going to let the natural process take place. When a person is on hospice, it's not just the patient, it's also the family unit and friends that are connected to that patient that we take care of. We are a support system to the patient and family. We not only provide physical care, but psychosocial, spiritual, help them access community resources. A new thing that's arisen is palliative care. Have y'all heard of palliative care? People? Yes. So palliative care and hospice kind of merge. So I like to talk about palliative care also when I'm talking about hospice. The palliative care philosophy, it's an approach to improve the quality of life. The thing about palliative care is it doesn't have to mean that that person is dying. It can begin at any time in a diagnosis of a disease. If a patient is diagnosed with CHF, they can begin palliative care because palliative care's focus is symptom management, keeping them out of the hospital, and helping them access community resources. Now they won't be treating the cardiac side of it, but with CHF you have edema, you have pain, maybe shortness of breath, and so palliative care's focus is going to be maintaining that. Hospice and palliative care. So hospice care is palliative, but it's at the end of life. So palliative care can maybe begin for that CHF patient in 1990. We're going to say this patient is diagnosed in 1990, but in 2000, they're now nearing the end of their life. They can now begin hospice care because that disease process has played out its time, and they're now nearing the end of their life and can qualify for hospice care. And the biggest thing about palliative care is they can be seeking curative treatment. So if you have a cancer patient, they can also be on receiving palliative care and chemo and radiation and any surgical intervention they need and receive palliative care, whereas in hospice they can't. Hospice admission criteria, they have to have a terminal diagnosis of less than 6 months. But we find that a lot of these patients actually do better once they've come onto hospice and live well beyond that. The longest I've known somebody to be on hospice was 5 years. And there's a certification period, so every so often they're assessed by the nurse and the physician to see if they still meet criteria for hospice. And if we can support why they qualify for hospice, we keep them on, and they can stay on as long as they meet that criteria. Can't be seeking curative treatment. Medicare is who governs hospice, and even if it's a patient who's not on Medicare, most insurances follow Medicare guidelines for non-cancer diagnoses. So if you have a CHF patient, we have certain criteria that that patient has to meet to qualify for hospice. There has to be a physician who will give us orders. If the patient's primary care doctor doesn't want to follow on hospice, then there is a medical director to follow. And they have to have a willing caregiver. That doesn't mean the caregiver has to live in the home, just somebody who can speak on behalf of the patient if the patient's not able to make their wishes known any longer. Referrals can come from anywhere, and it can come from a patient, a family, physicians, hospital, home health. You guys can even make a referral to a patient about a patient needing hospice. If you're with somebody who maybe calls a lot for a chronic illness that has lots of problems and you've seen them just kind of declining, you can even approach them with, hey, have you ever thought of hospice? So it can come from anybody in the community. It does not have to come from a physician. We collaborate with physicians, hospital staff, nursing homes, home health. We try our best to make sure that we work as a team with whoever is involved in that patient's care. The initial hospice orders has to come from a physician who says, yes, this person is expected to die in 6 months or less. Some of the services that are provided from hospice is nursing. There will be nurses who come out and see him, social workers, counselors, certified nurses' aides, chaplains, and volunteers. We also provide physician services. A doctor has to have a face-to-face contact with hospice patients. So whether it's the physician going to that person's home or that person going to the doctor's clinic, there has to be a face-to-face visit. We cover any medications that would be related to that patient's terminal diagnosis. We provide respite care, and that's where they can go and stay somewhere for about 5 days so that the caregiver can have relief or go on vacation or whatever it is that they're needing. We cover medical equipment, bereavement. We do some physical therapy, occupational therapy, and speech therapy, and we do inpatient care if necessary. These are the various nursing positions, and I'm just going to kind of skim over this because it's just something you may not really care to know about. But some of the things we we can do in the home, we do IV management, we drain fluorexes, manage multiple wounds, trach care, we help with manage medication, we do PCAs in the home, tube feeding. This is just some of the things that we help with. Our focus is a lot on pain and symptom management and whatever disease process may be going on. We had a patient who's on our service for heart failure, and other issues were going on, and finally we just drew labs on her because everything we were trying to do to help with her dizziness and her syncope and her passing out wasn't working because we thought it was blood pressure related, and it turns out she was also a long-term diabetic, and her caregivers had quit managing her, checking her blood sugars. Well, her A1C was very low. She was hypoglycemic. So we do manage things like that. Death. So we're 24/7 because death happens 24 hours a day. For hospice, the nurse makes the visit and pronounces the patient's death in Lubbock County. There are some surrounding counties that prefer to have their JP called, and we have a list of those that we need to call if we're in their county. We cover 19 counties, so we try to make sure we're aware of each county's rules. We do post-mortem care, we destroy medicine. We contact the funeral home when the family's ready for the body to be released. And I guess how this can be tied to you guys is sometimes families panic and call 911, and you guys get there and maybe it's a family who hasn't decided to sign an out-of-hospital DNR, and being married to a paramedic, I understand that it's really important to have that out-of-hospital DNR. And we know that creates a little problem for you guys because you guys are required to begin, I guess, life-extending treatment if the family calls you guys. I know some people will call the hospice and allow the hospice an opportunity to come out. However, it is patient and family choice if they want to be coded. They do not have to be a DNR and be on hospice. That's kind of that gets kind of muddy for a lot of people, especially when you're in emergency care, because your goals there are to provide intervention for these patients who may be declining. And sometimes while their body's physically ready to die, their brains aren't quite there yet. Our goal in hospice, though, is to, maybe when we first admit them on hospice, they aren't ready to say, I want to be a DNR. And how we approach it is an A and D. Do you want to allow natural death? If they say yes, we then try to talk to them about the out-of-hospital DNR. And while the patient's able to make their own choices, our approach is, we try to tell the patient that if they do not make their choices known, then it's left to the family to make those choices. And for most patients, they don't want their family to have to do that for them. So we're able to get them out of hospital DNR. And we always tell them that if they have that in place, but then change their mind, they can get rid of it. However, if they don't have the out-of-hospital DNR in place, and they don't want to be intubated and put on a vent and taken to the ER, that's what's going to happen if they don't have the out-of-hospital DNR. But yes, they can remain a full code and be on hospice. Healthcare reform has impacted hospices, like I'm sure it's impacting everybody. I'm not sure how it impacts EMS, but used to we got paid a set amount, and now we get paid this much at time of admission, and smaller and smaller and smaller amounts until the time of their death, and then you get another payment. So it's kind of weird, and all hospices across the board got a 2% cut in funding. Okay, myths is a patient must choose to be a DNR to elect hospice. That's a myth. It is illegal for us to require a patient to sign a DNR as a condition for hospice services, and that's actually in the regulations of Medicare. A patient cannot receive medical treatment on hospice. They can, if it's regarding their hospice diagnosis, if it's a cancer patient, they can have treatment if it's considered comfort care. If it's a cancer patient who's a diabetic, they can still, and is on dialysis, they can still get dialysis for their end-stage renal. Hospice patients cannot call 911. They can call 911. We urge our patients to call us first because we do our best. There's a lot of things we can do in the home to avoid having to call EMS or to go to the emergency room. We can draw blood, collect urine, do x-rays in the home. We can get medication emergently if we need to. So we do our best to have them call us, but again, families sometimes panic and we'll call 911. Sometimes a patient has had a fall and they may call hospice first, and we may get there and we may not be able to get them up off the floor. So I know I've called the non-emergency number, and I've had some of these guys come and help me lift people up off the floor because I just can't, and it may be that their caregiver is just as frail and elderly as they are. But so we do call, they do call 911. We do tell them if it's a true emergency, meaning they fell, they hit their head and they're bleeding everywhere, then call us, and we will either meet them at the house or meet them at the ER. But they are allowed to call. And this is a big one that I hear: a patient can never return to the hospital. And that's not true, because we go back to the hospital sometimes for things that we can't take care of in the home. Sometimes pain and symptoms are out of control and we can't manage it in the home, and we have to go back to the hospital. We do try to have that already set up so that they're direct admission, and we call one of the local ambulance services to help us with those transport. They can also revoke hospice at any time and go seek curative and aggressive treatment if they want. And they can be hospitalized for any other illness that's not related to their hospice diagnosis. Something that's not uncommon to see is they'll have a fall with a hip fracture, and if it's not related, and even if it is related, because the hospice should still be responsible for that, is they'll get it surgically fixed, because that's a comfort measure as well. So yes, they can return to the hospital. Some of the things we hear is there's nothing else we can do. Well, sometimes there isn't anything medically left that can be done for a patient, but there's still things we can do to help that person. Just like y'all are called to EMS, some of us are called to deal with dying. It isn't sad all the time. Sometimes it's a good thing when somebody's died, because whatever they're going through is much worse than dying. We're not angels. We have poor sense of humors, and just like y'all. I could never do that. Well, I can't do y'all's job either, because that makes me sick to ride in the back of the ambulance. They don't all die. I've actually seen 3 people discharged off of hospice, and 2 of them are still alive. And they came onto hospice and they had poor symptom management, poor management of their disease. And once somebody came in and was routinely seeing them and managing their care, they actually improved well enough. They came off hospice, and one even went on for a transplant and is doing well. One did actually die, but she had 6 months of hospice-free life and doing well before she came back to hospice and died. And we are still real nurses. That's a question I get asked a lot, is why did I do hospice? Because I'm not a nurse now, but we are all still nurses. We still use our stethoscopes and stuff like that. And this is about Hospice of Lubbock. But questions? Anybody?
I have one.
Yes.
The 2 calls that I've been on, not recently, it's been a little while, is I know when a family member is placed on hospice, you have a protocol, I guess, that you explain to them on events that can occur, you know, even with death. The 2 calls that I've been on, the family called, the patient was on hospice, the patient was DNR. The only reason that we were transporting and they called us is because they did not want the family member to die in the house.
Yes. Dying in the home. Hopefully, we hope that that patient's nurse has asked where that patient wants to die, where the family wants that person to die at. Most people want to die in the home, want to die at home. Here, we had a patient not too long ago who, the day he died, he told his family, "I don't want to die here. I want to die at the hospital." And he died literally on the gurney as he was being going to be transported to the hospital. He was on the walkway outside of his house. We try our best to avoid those situations, because that's not fair to the patient to be where we're in a rush to get them out of the home and get them somewhere, and it's not fair to EMS, who that is not what y'all do. And it's never ideal for somebody to die on a gurney outside of their house or in the ambulance on the way to the hospital. You just hope that people have done their jobs and followed through to make sure where that person wants to die. And as that person gets closer to death, that we're preparing the family, okay, your husband is making this change, this change, this change. Death would not be unexpected, you know, in the next couple days. Hopefully that's what we hope to do, but sometimes doesn't happen.
I didn't know exactly what to do because, the family didn't want us to do anything because they had a DNR, but they didn't want him in the house.
Yeah.
So,
And that's something that should be really asked when they're admitted, or if it's not even asked, they need to say, we don't want this to happen in the home. Some people, that's what they're waiting for, is to be home. Others, doesn't happen. So, yeah. My best advice is ask them why they don't want to die at home. If you're ever in that situation, some people are afraid that the body is going to be left there, or it's going to take a long time for the funeral home. Sometimes it does take the funeral home a long time, but sometimes it's because they're just really afraid that they're going to be in more pain at home than they would be somewhere else. Any other questions? No?
Speak now.
You can ask me anything.
Remember, who she's married to.
We do, like we said, if we know that we're going to be transporting them and they want to be a DNR, we try to have a DNR in place so that y'all aren't ever put in that situation. With a couple of the outer lying counties, we've had to transfer patients home, and I know for one paramedic, we literally extubated the patient in the ambulance bay of the hospital, and I told him, get in your ambulance and don't stop until you get there. And his question was, what if he dies? Keep driving, and when he gets there, we'll put him in the bed and I'll pronounce him. Because this patient was dead set to get home, and he was out beyond post. And they had tried to wean him to extubate him, and he failed. And so the whole time I was behind the ambulance just thinking, oh my gosh, she's going to die, and that paramedic's going to be so mad at me. There was a DNR in place, but at the same time that was also a friend of his because he was from that county where that man lived. But this gentleman ended up, we extubated him in the ambulance bay, and he ended up living another 2 weeks. And he was awake. When I left the house that day, he was head of the bed, was up, and he was talking to his family. So even though he was failing medically with medical intervention, going home is what he desired so much that he rallied, what we call rallied. Sometimes we'll have patients who have a burst of energy right before they die, and that's usually when we see our falls. They get up and they haven't been able to get somewhere in the house, and they'll get up, and that's when they'll have their falls, and that's when we're calling and saying, we need some muscle to come pick this person up. So those are some things we see. Sometimes, I know I've had to call EMS I call 911 for whoever would come and rescue me because combative patients. At the time, we weren't for sure what was going on with this gentleman. He was 90-something years old, and he had destroyed his room, and he beat me up in the process and tried to choke me with the extension cord. And when I finally got free, his son had just had back surgery and was a mess on the floor. And I got out and called 911, and it took, I think the ambulance was there over 10 minutes, and they'd given Versed, and I went to the ER following to meet the patient there, and he was still sitting up on the side of the bed. And it turned out that he had a severe case of terminal restlessness related to PTSD from World War II. They began doing some delving into his history, and he actually ended up dying less than 24 hours later. And that terminal restlessness, sometimes we'll see that with patients, and it's, for him, that was the severest form we can see, is when they're like that. He was naked and bloody and beating everything up, and this little man had destroyed his room, and so sometimes we'll call for help like that because we can't manage that at home. We need help. That's a situation where we would probably need EMS. Sometimes it's family who needs EMS because they become so overwhelmed with their own feelings that they need some help from the ER. So I have seen that where family members had to go get treatment because they're so overwhelmed with what the patient's going through. So.
Are you the only organization in town?
No. There are quite a few hospices in town. Hospice of Lubbock is who I work for. We are owned by Covenant. We are the only nonprofit in Lubbock. We are the only hospice that also manages pediatric hospice patients. So we take anybody regardless of their ability to pay. So you may hear about beans and cornbread and a couple other fundraising events, and that's how we pay for patients who are unfunded or underfunded. Unfunded is what it is, no insurance, no way to pay. And underfunded is what I like to say is those people who's my age, has private insurance, but now has a terminal illness and have capped out of their insurance, and they're out of funding, or they're underfunded. They may have a ridiculous copay or deductible that has to be met before they can receive hospice services, and we take them regardless. We have had 2 homeless people on our service, and that's interesting, to work with a homeless person who's on hospice and dying, to find them somewhere to die, other than on the street. But we're not the only ones. There's several good ones out there. I tell families, if you're talking to somebody about hospice, call a couple, interview them. Every hospice has to offer the same thing. All the things I talked about, every hospice has to offer that. Sometimes it's a little harder to get some of these hospices to offer it because it means more money from their bottom line. So it's just a different philosophy.
I have a question.
Okay.
We have some newer paramedics that are not familiar with seeing patients in their final moments of death. Do you mind describing some of the sights, sounds, smells that they might see so they're not worried about what is this?
Okay. Yes. So patients look different as they're dying, and there's different stages. They can start to look blue-purple on their hands or like bruised on their legs. We call that mottling. They may be cold and kind of stiff, but they're not dead. Maybe kind of more of a waxy appearance. Their breathing can be, it's chain stoking, it's fast, then there will be pauses, and then they'll be fast again. That's normal. If you're looking at them and trying to make eye contact, they may be looking beyond you. They often talk about people who are already dead and be seeing people who are no longer with us, or animals or children. Those are all common things. A big thing about dying is you no longer have the desire to eat and drink, and for most families that's very distressing because you have to eat, you have to drink to live, and it's actually very normal for them to quit wanting to eat first and then quit drinking late after that. And we try to encourage families not to push feeding or fluids on patients who are not wanting it. As far as seeing other people, we just don't play into it. We just let them talk about what they're seeing. You know, sometimes you want to you hear different methods, you either give in and say, yeah, you're seeing whatever they're seeing, but we just let them talk it out when they're talking about what they're seeing. But if they're saying they're seeing somebody who's died or different things like that, that's not uncommon. They do become incontinent of bowel and bladder. They do develop certain wounds and sores that are different from bed sores. They're called Kennedy ulcers, and that's usually, they will appear within within about 2 days of death. They'll appear. It is true that earlobes will start to lay flat as a person is dying. It may have been a confused person who has a sudden moment of lucidity and can actually have a conversation with you. That sometimes happens. And smells vary from the disease to disease. Some cancer patients will smell outside of the house. You can smell them from outside. We had one patient that we moved her to the hospital not because we couldn't manage her symptoms at home. Her odor from her cancer was so bad, when I parked on the street and walked up the driveway into her house, you could smell her in the driveway. And her little husband just, it was overwhelming. Even in the hospital when we admitted her there, they had coffee filters and kitty litter everywhere, and you could still smell her down the hall. So sometimes the smells are bad. And we do take patients who have VRE, MRSA, and C. diff, so those are things we deal with in the home as well.
I have a question.
All right.
All their medications stay at home? Or
When
do
they
y'all
die?
manage it? No. Do y'all manage their medications, or do they have free range of taking their own medicines?
Medicines stay in the home with them. We do manage it, but it's still their home, and it's their choice if they want to take them as they're prescribed or abuse them or just not take them at all. We do have a policy that if they're abusing their medication, they're just not going to get that refill early. We just won't do it. We do deal with everything from just plain old Tylenol to the benzos and morphine and Dilaudid IV, and some of the morphine bottles are about that big. It's 30 mLs, and that's 600 milligrams of morphine in that 30 ml bottle. When they die, we do ask to take the medication. However, if the family wants to fight us for it, we just leave it. We won't fight for it. Yeah, they can manage their medication, and some are really good and some aren't, and sometimes families are really bad.
Okay, so the next question is, if it's intentional, morphine overdose, and you get there no respirations, but they do have a pulse, or they're agonal.
If they intentionally overdose on the morphine?
Yes, ma'am, and you do have Narcan to reverse it. How does that fall?
Okay, so we had a patient recently who was not on hospice yet, but he had attempted suicide. He was a chronic pain patient with COPD, and he had been on another hospice. And while on their hospice, he did intentionally attempt suicide with his opioids and his benzos. And they Narcan, it threw him in withdrawal, severe pain. It was just a nightmare. That hospice discharged him off for attempting suicide and not following the plan of care. We did pick him up and admit him, but with kind of a contract in place, and we kept all his opioids and benzos. Now, he could keep his blood pressure meds at the house, but the scheduled drugs, the class 2s and 3s, we kept at the house, at our office in a lockbox. So, and when he needed those, we went and dispensed them, so that he never could do that. There are situations where families may feel like the patient has received too much pain medication, and if they have, we don't really want Narcan used, because if it was a difficult patient to get the pain under control, you send them straight into withdrawal and into a pain crisis, and it makes it a lot harder. So if it's somebody we suspect that has taken too much morphine, we're on the phone with our medical director. What does he want us to do? And we go from there. But we found with one person whose family didn't understand the directions on lorazepam well, that just holding and going in and checking the patient, letting the medication clear on its own, it actually ended up being a good thing. That patient was comfortable, it resolved itself. So it just depends on the situation. But we try to avoid Narcan if possible.
Okay, so in that situation, if we arrive on scene and, family tells us that, because we've all seen, or a majority of us have seen those patients that you give Narcan and you take them, you put them in withdrawals, and you do it once and you never do it again because it's cruel. And so you get there and family tells you that, you know, they have called hospice and that, you know, they know that their family member overdosed. Should we wait until you arrive, just ventilate the patient, or what's the fine line on that?
Go with what the patient family says.
Just
If
go
they
with
want
them.
you guys to do something, I would do what they ask, because it's ultimately going to be them who makes the choice anyway. And because my thought on this is, if the nurse is 30 minutes away from getting there and the family's wanting something done, don't wait for us. And hopefully you guys get the chance to talk to the hospice nurse to find out. But if the family's wanting something done, I would do what the family's requesting, is what I would do. Because that's,
What about just titrating the Narcan to effect?
that would probably be the best, be ideal. Start low and then just,
Yeah.
yeah.
And that's where we're at now in our treatment of opiate overdoses, so.
Yeah, and I don't know if y'all are aware, but Norco has come out in an extended release form, and that's something hospices are choosing to stay away from because of the abuse. And we use Norco a lot, but it's the short acting, and now that they have the long acting, it's something y'all might see more of, and it would be accidental for most people because they're not going to understand that this medication that they used to take when they needed now comes in extended release, and they're going to be at greater risk for accidental overdoses. So I would for sure titrate to effect. But
Any other questions?
Okay.
Well, thank you so
Thank
much
you.
for coming.
All right.
You know, we all run into these patients ever so often, and, you know, sometimes it's confusing, I guess, in my opinion, on you see one thing and you have family telling you another thing, and
Yeah, and that's why I try to tell patients to have what they want already set in place, so the family doesn't have to make those choices. But then we're also in the situation where if that patient's unable to make their wishes known, the family can make their wishes known, and it may not be what the patient wanted. So it does seem contradictory at times, and it's really just about educating the patient and the family about the disease and dying. And that's the best we can hope for, is that they've been educated well, that somebody's talked to them openly, honestly, bluntly, brutal about it if they have to, so that they can better understand. And hopefully it didn't just come from the hospice nurse, hopefully it came with the diagnosing physician, which sometimes it doesn't. Okay.